Welcome to the lecture on the heart. My name is Suarez-Quian. I am the author and narrator of this lecture. In the first part of this series, we discuss the mediastinum. Here, we present the coronary circulation. We start the discussion of heart circulation by looking at the isolated heart on the left-hand panel. We're looking at the anterior view of the heart. The heart will have a right side and a left side. If you look closely, you can almost make out the right and left ventricles. What is preventing us from truly seeing the various chambers of the heart from this anterior view is the abundant fat that is present in this heart. And this is not even a great amount of fat present on the heart. Go back to the earlier discussion on heart disease that is present in citizens of a modern industrial society. If we now remove the fat from the heart, shown in the middle panel, arteries are exposed and evident, but also the appendages of the atria, the auricles. The auricles are not the atria. The atria are the two chambers of the heart that receive blood. The auricles are muscular pouches that extend from the atria and increase the holding capacity of the atria when needed. The right and left ventricles are now evident. Appreciate that in the anatomical position, the right ventricle is found on the anterior surface of the heart, the right atrium makes up the right margin, and the left ventricle makes up most of the left margin of the heart. If you now focus on the arteries, they reside in depressions of the heart, and these depressions are called sulcus. The plural is sulci. The sulcus between the atria and ventricles is known as the atrioventricular sulcus, whereas the depression between the ventricles is known as the interventricular sulcus. Given that this latter sulcus is present on the anterior surface of the heart, it is more appropriate to call it the anterior interventricular sulcus. Moving now to the posterior aspect of the heart, panel on the right, the left atrium finally becomes visible. The left and right ventricles are also visible. As before, we see the groove separating the left atrium from the ventricles, and this is the continuation of the atrioventricular sulcus. In between the right and left ventricles, we also see a groove. Now it is termed the posterior interventricular sulcus. Let's now describe the coronary circulation of arteries, which, by the way, are so called because the arteries sit on the heart as a crown. Corona is Latin for crown. On the left panel, we have a drawing of the typical coronary distribution one sees on the anterior surface of the heart. On the right panel is a dissection of the heart demonstrating the coronary arteries. The right coronary artery emerges from the aorta and is found in the atrioventricular sulcus. Although various branches can emerge from the right coronary artery onto the surface of the right ventricle, the only artery that is granted its own proper name is the right marginal branch. On the interventricular septum, the anterior interventricular artery is evident, or commonly referred to as the left anterior descending, or LAD for short. Anatomically speaking, the anterior interventricular artery is not the left coronary artery. It is a branch of the latter. The left coronary artery can be observed in the dissection, but not directly emerging from the aorta. The last artery we see is considered a diagonal branch from the anterior interventricular artery. There can be several or just one, as in this case. I now show you different drawings of the coronary circulation to affirm that depending on the illustration you are examining, the coronary artery circulation will vary. This is so with patients also. On the anterior view, I again label the arteries I showed previously: the right coronary, the marginal branch of the right coronary artery, the anterior interventricular artery, and the left coronary artery. Note that in this rendition, the left coronary artery is illustrated in the drawing. But now there's another artery not mentioned previously, the circumflex branch of the left coronary artery. This artery continues within the atrioventricular sulcus to reach the posterior aspect of the heart. Getting back to the right coronary artery, note how it too stays within the atrioventricular sulcus and proceeds to the posterior aspect of the heart. It may give off several unnamed arteries, but ultimately, when it reaches the posterior interventricular sulcus, a main artery will arise, the posterior interventricular branch of the right coronary artery. I should emphasize that this coronary artery circulation pattern is the most common. Approximately 85% of us are what is termed right coronary artery dominant. That is, the posterior interventricular branch arises from the right coronary artery. However, in up to 15% of individuals, the posterior interventricular artery can arise from the circumflex artery, in which case the patient will be described as being left coronary artery dominant. If one does not develop coronary artery disease, there really is no disadvantage to being left coronary artery dominant. The coronary veins follow the arteries, and they too are given specific names. Accompanying the right coronary artery is the right coronary vein, or more frequently now termed the small cardiac vein, a continuation of the right marginal vein. Traveling with the anterior interventricular artery is the anterior interventricular vein, which, as it approaches the right atrium, is giving a name change to the great cardiac vein. Note that in the dissected heart, the veins accompanying the right coronary artery are difficult to discern. This is a general problem with dissected hearts unless great care is taken to preserve the veins. The great cardiac vein, however, is generally well preserved. The posterior interventricular vein will be accompanied by the middle cardiac vein. Note that this vein is also readily discerned in the dissected specimen in the posterior view. Ultimately, these three veins that I've described will drain into the right atrium. However, they do so by first emptying into the coronary sinus, a readily visible vein formed from the great cardiac vein. The coronary sinus courses in the atrioventricular sulcus, and it is the vein that empties the coronary circulation into the right atrium. There are small veins that drain directly into the right atrium. These are the anterior cardiac veins. As you can see, they're not even included in the drawing and missing from the dissection. Now that you know all about the coronary circulation, I can discuss coronary arteriograms, a procedure in which a catheter is inserted into the femoral artery in the thigh and threaded all the way up to the opening of the coronary arteries where they begin at the aorta. A radiopaque dye is then released and the dye can be imaged using X-ray technology. On the left, a drawing of the right coronary artery is depicted as it would be viewed from the side, and on the right, an actual image of a right coronary artery arteriogram is presented. The right coronary artery is now indicated in both images. Note the continuation of the right coronary artery as it becomes a posterior interventricular artery. In this drawing, a sinoatrial nodal artery can also be imaged. I did not mention this artery when discussing the coronary circulation. It is very small and not easily dissected. First-year anatomy books often do not include this artery, but it should be mentioned now in the arteriogram. Note also the presence of the catheter used to perform the arteriogram. This is not an artery. Here, now we see the drawing in the actual left coronary arteriogram. The left coronary artery is labeled in the drawing and on the arteriogram. Note, this is the left coronary artery, not the anterior interventricular artery. The actual anterior interventricular artery is now indicated, a branch of the left coronary artery. The other major branch of this artery is the circumflex artery, now labeled. If you're wondering whether coronary artery arteriograms are a rare event, let me dispel such a notion. It is estimated that over 1 million such procedures are performed annually. The question now becomes, who was the first person to attempt such a procedure on a patient, and how did that patient consent to such a dangerous procedure at the time? The story can be traced back to Werner Theodor Otto Forsman, a German physician who graduated medical school in 1929. While a medical student, he inserted a cannula into his cubital fossa vein and drove it to his own right atrium, walked to the X-ray machine, and then imaged the catheter in his right auricle. Based on his insistence that the procedure was viable, he was forced out of his residency program and was relegated to being a urologist, not a coveted discipline in that era. He became a prisoner of war until 1945. He did join the Nazi Party, but he did publish his findings, and in 1956 he was awarded the Nobel Prize in Medicine along with Andre Coronary and Dickinson Richards, who had read his early work and based their own pioneering coronary artery arteriograms on Forsman's work. In this drawing, you can now see why people make such a fuss about the coronary circulation. Plaques form within these arteries, and in time, these plaques can lead to severe angina, pain in the heart, due to blockage of the coronary arteries to an affected part of the heart, and if left untreated, likely death from a heart attack. Here, I again show you the schematic, most common form of coronary artery circulation. I identify the left coronary, dividing into the anterior interventricular branch and the circumflex branch. Here's the right coronary artery, dividing into the marginal artery and the posterior interventricular branch. Now focus your attention on the location of the plaques indicated by the yellowish squares. The most common site of plaque formation is the anterior interventricular branch. It is for this reason that this coronary artery is called the widowmaker. The next most common site is the right coronary, and the third most common site is at the circumflex branch. Of course, plaques can and do form at other sites, but the three sites indicated are the most common sites of pathology. One question that students often have is, why does the heart tissue need its own circulation, given that there is so much blood within its chambers? Why does this blood in the chambers not suffice to supply the heart muscle with nutrients and oxygen? The reason most often given is that the heart tissue is quite active and it requires blood at a faster rate than the blood within the chambers can diffuse through the thick heart muscle and provide the nutrients and the oxygen. The question now becomes, given that a plaque has formed and it is blocking blood circulation to a part of the heart, what to do about it. Initially, surgical skills improved and a heart-lung machine was developed to oxygenate the blood. Thoracic surgeons learned how to bypass the blockage by connecting veins to the aorta and attaching them distal to the sides of the plaque. Other strategies deployed are illustrated in this slide. A balloon catheter was inserted into the arteries and driven to the site of blockage in the coronary arteries. On the right panel at the top, one can see the deflated balloon catheter approaching the blockage. The balloon was then driven into the plaque and inflated, removing the blockage. After withdrawing the balloon, the circulation was reestablished. While this approach worked, unfortunately it was not permanent. The plaque reformed. Using a similar strategy of inserting a catheter, perhaps one of the greatest advances in all of modern medicine was the development of stents to alleviate the symptoms of coronary artery plaques. As demonstrated in this netted drawing, stents were delivered to the site of the plaque and deployed, pushing the plaque aside and reestablishing circulation. Although stents gained significant popularity following their introduction in 1986, if a coronary is completely blocked by plaques, coronary artery bypass surgery is still favorably recommended. A bypass can last over 10 years, especially if an artery is used for the graft instead of a vein. By the way, the first coronary artery bypass was performed in 1964. The team was led by DeBakey and became the gold standard for treating plaques. Today, most bypass surgeries will use the left internal artery as the graft, a procedure term, LITA or LITA. This now concludes the second part of this lecture series.